Thank you.
Yes.
So Dr. Bancha from Thammasat University Hospital, thank you for the invitations. I'm talking about the full thickness rotator cuff tear repair, the current concept. So if you see the etiologies, many cuff tear, nearly 25 to 50%, have no symptoms. So not every rotator cuff tear need to be repaired. And also the tear progression in degenerative cuff tear is not so fast. You have time to wait. You don't need to repair in every patient. So the tear progression is about 37% at nearly 4 years, right? So if the patient have the weakness supraspinatus, infraspinatus, also impingement side, most of the time, nearly 100%, this patient have the chance of cuff tear. So I focus in the practical part. So in my practice, I use 3 X-ray. First, AP1, we want to see the AHI. Is it good? Most of the time, this cuff is repairable. Another one is the caudal tilt view, 30 degree. Okay, many times you have this pathologic spur. If you have this very sharp spur, you need to decompress, right? So if you have heel spur, you have irregular spur, you have broken osteophyte, okay? This kind of spur, you need to be decompressed, okay? And also outlet view. Outlet view is not easy to take for the technician because sometimes the clavicle block the view. So my preferred view is this caudal tilt view, 30 degree, okay? MRI, okay, is important. So this is the bone morphology and the association with the cuff tear. If you have larger critical shoulder angle, higher acromion index, lower lateral acromion angle, and type 3 acromion, this is significantly associated with the degenerative full thickness rotator cuff tear. So this is my articles. We conclude that the acromion at least is that if there's a rectangular, we call this heel spur, or this heel spur, and also irregular spur. This kind of spur you need to be decompressed, right? And if you classify the cuff, okay, we're just talking about this full thickness tendon tear, right? It can be the avulsion from the tendinous part, or mid substance tear, or it's like type 2 tear, Fosbury fork tear, and bony adhesion, right? So these are there's many classification depending on the size of the tear by Collins classification, tendon retraction by Patek classification, and also the tear pattern, right? So this is a Collins classifications. Yeah, they classify the cuff into 6, right? They have upper subscap, lower subscap, also infra, teres minor, supraspinatus, right? Patek is easy to remember. You can easily grading. Okay, this is type 1, type 2 is on the head, type 3 on the glenoid, right? So Patek is very popular. And also the size I think is depending on the less, like our Asian size and the European is different. So I think this size is not so good for classify the cuff tear, right? Small, medium, large, and massive. Also, you can classify by the tear pattern, C shape, U shape, L shape, reverse L shape, right? So nowadays we have more and more type 2 tear. This is type 2 tear. The tear is proximal to the footprint, right? And that associated with the knot tying. And this kind of tear, sometimes you have a flat tear like this. Most of the time it's coming from trauma, okay? So there's no difference in rate of tear progression between the symptomatic cuff and the asymptomatic cuff, right? About 34% at 4 years, right? So we always try conservative treatment before doing the cuff surgery. We always do steroid injections, physiotherapy, rehabilitation. Every patient, even you see the full thickness tear, okay? So the steroid injection, many surgeons afraid of this injection because they saying that the steroid injection before cuff repair may have the problem of healing process. But from this article, we found that there's no problem, there's no association with the tendon healing, okay, with the steroid injection. So you can try steroid injection before the surgery. Yeah, that's a part of conservative treatment. Operative treatment indication, yeah, for the severe chronic pain that not responsive to conservative treatment. Acute traumatic cuff tear, okay, always do surgery. And symptomatic moderately large chronic tear, okay. So this is indication for surgery. I prefer beach chair position, okay, because I can easily go around the shoulder, okay, especially for the lateral roll. Yeah, I think it's quite important. I have 5 portals for the cuff repair. There's 1 in the back, 2 on the side, right? This is my wing portal, my working portal. Another portal for ankle placement just in front of the AC joint. Another one is lower, okay? Sometimes you didn't need this one, okay? But in massive cuff tear, I always use this one for bicep tenodesis and also for the massive cuff repair, okay? Most of the time we have 4 to 5 portals, right? So first, we need to do very minimal CA ligament detachment, okay? So if you have pathologic spur, you need to do decompressions, okay? And after that, we switch the portal to check the acromion again. So this patient changed my practice. So I did this patient many years ago, and I did very nice repair. But the patient come back with re-tear. You see that? At that time, I do not tying, and the patient come back with tear proximal to the footprint. You see the footprint heal nicely, but the tonsile is close to proximal, right? So, and I read this article, Dr. Yongali, he's mentioned about not tying can create the type 2 tear or the tear proximal to the footprint, and he encouraged to do the knotless, okay? If you look at this article, you see that the vascular blocked by the knot tying, okay? So that can jeopardize, that can make a strangulation of the cuff and can be the type 2 tear, okay? So the type 2 tear is up to nearly 60% from this article. So I did the study comparing knot tying and knotless, okay? So my knotless tying, I use triple load anchor. So we have the totally 12 sutures, and I try to separate my suture on the footprint. And we found that the pressure contact at the footprint on the conventional have higher, okay, significantly higher comparing to the knotless. So that proves that the knot tying can strangulate and make a type 2 tear because there's too much tension on the medial side. And also the footprint contact area, you use a knotless, this is a knotless group, okay? We have the better footprint coverage by this technique we call Dosen. That's been 12 knotless suture bridge technique. This patient come back after cuff repair, okay? He had the type 2 tear. It's tear proximal to the footprint. So when we get in, we found that the tear is exactly at the medial footprint, right? But the lateral row healed nicely. So this technique we call the knotless suture bridge technique. We pass the suture like tension band, okay? Fix the cuff back to the lateral row without knot tying, okay? And we have very good result using this technique. Patient come back with good result and good healing after the surgery. So I love this technique so much. Dosen knotless suture bridge technique, okay? And I did this study. We found that the re-tear rate is significantly less comparing to the knot tying, okay? In pattern 2, I have nearly 0% of re-tear, and in pattern 3, I have 30% of re-tear comparing to the knot tying group. And one day, yeah, I got the suggestion from Professor Juhan O. He said, you put the camera inside the joint, okay? This knot, I didn't tie it, but in the back, I tie it. You see, comparing the knotless and knotted, right? When I put the camera in, you see that it's different. You see the gap between the rotator cuff and the footprint. When you tie the knot, it's okay, yeah? So now I'm confusing. But anyway, I look at my study and my result, MRI, even they have a gap like that. But anyway, the cuff can heal nicely, okay? I'm not sure that the fibrous healing or something, but the cuff heal nicely, and also from our study, the result is pretty good, right? And some study mentioned about knot tying, re-tear rate is less than knotless. So now there's knotted and knotless. That's quite controversy. So I think I will be in the middle. I will be not partial knot and knotless, okay? But anyway, we keep the same concept of the tissue tension-free repair and footprint coverage. Okay, so like this patient, I did the triple loaded anchors. So we call this the 3-in-1 hole passage. Okay, so I try to widen my footprint by putting 2 anchors. We put 2 anchors, but this triple load. You can see from the diagram. So one hole you have 3 sutures. So the 3, totally 12. But you have only 2 anchors. These 2 anchors is triple loaded. Okay, so you have very little damage to the cuff because you have only 4 holes only. But this suture with spreading and cover the footprint, okay, of the cuff. So that is my concept. I will try, and I just tying the knot only partial. Okay, like you have the crescent tear, I will tie like this in the front, in the back, and sometimes in the middle. So we have about 2 or 3 knots tying only, right, to make sure that your footprint is attached, okay, to the cuff is attached nicely to the footprint, and then we spread the sutures, okay, like that way. Okay, and for the lateral row, okay, we make it 6 and 6. Okay, so many companies now, the 1 anchors on the lateral row, you can put 6 sutures, and this suture distribution, like our study, you have better footprint coverage. Okay, and this is quite speedy because you have only 4 holes in the rotator cuff. Okay, so it's quite fast, and this is our final pictures, okay, of the cuff repair, right? It's quite nice and nicely spreading the sutures. So we put the average leg cord, our first anchors, okay, to the last anchor is only 23 minutes 8 seconds because it's quite fast. You just put 4 holes in the cuff and do minimum knot tying. But the key point is you need to spread these sutures front and back. Okay, it's making very wide attachment of the rotator cuff. Okay. So that is at our lateral low, like someone asking, if you have osteoporosis, most of the time I will put my anchors close to the biceps in the front because at that area, in the groove, the quality of bone is good. And also in the back, I put it close to the infraspinatus insertion. Okay, so you have the good bone quality because close to infraspinatus insertion is the cortical bone. So good bone qualities. Okay. So for lateral low, you try to make it very wide front and back. Okay, so that is the lateral low footprint, right? So this is article is very nice. If you put the suture too close, like you go many sutures, less than 5 millimeters, you can have the cut through. Okay, because you strangulate and you cut through this tissue. Okay, so my average distance between that is about 7 to 8 millimeters. Okay, and when you go in, you need to decide. Okay, on my first suture, I will put in the comma tissue, very anterior, not in the cuff, in the comma tissue. Second one, third one, and fourth one, like that. The fourth one put in the infraspinatus. Okay, so your suture will spread widely. Okay, and that's the way of our repair. We put triple load anchors, and we tie some knot like this L shape. We need to repair the apex, right? After you repair the apex, the cuff will be like C shape, and then you put your anchors front and back, okay, like that way. Okay, you will have the very nice spreading of your sutures and better footprint contact. So when you tie the knot, we go this way. You see, that's 2 knots. You cannot pass 3 knots in one time. The trick is you pass 2 knots in one hole first, and then another knot. Then you can pass these 3 knots into the hole, right? If you go 3, that's impossible. Okay, so that's the way. That's the trick to go for 3-in-1 hole, right? And for the lateral low, it's the same. I put first one very anterior, and the patient external rotate. The posterior one we go internal rotate, so you can have the very wide distance between the anterior and posterior. Okay, this is the final repair after you make a knotless. This is the 3-in-1 hole hybrid suture bridge technique. Okay, this is a very massive cuff tear. You have the patient have pseudoparalysis and proximal migration, patent 3, and also infraspinatus tear. So that's very big tear, and also at the beginning you cannot repair the cuff back. So our concept is that you need to have a very good and tension-free repair. Okay, so this kind of massive tear, first you need to go very good mobilizations. Okay, detach the cuff from the roof, decouple the cuff from the coracoid process. That is coracoid process, right? That is AC joint. Okay, important that you need to release the cuff to make it tension-free. Okay, like that way. Okay, very good release. So before tying the knot, I think you should spend this time for the cuff preparation. Okay, not jump into the cuff repair. Okay, so I take a long time for this preparation before I starting to do repair, because the timing of repair is just 23 minutes, right? But this preparation you take long time. Okay, and then we make this technique, the 3-in-1 hole. Okay, so this patient I put the 3, the medial row I put 3, most of the time I put 2 because it's extending to the infraspinatus. Okay, and finally you can have this final repair. Okay, so yeah, we put to the lateral row. This patient I put 6 or 7, I'm not sure, right? And then you have the very wide attachment like that. Okay, this is a massive tear, traumatic, and he's come very late. Yeah, and also anyway you have a good functions and also good strength after the surgery. And this is the nice healing of infraspinatus and supraspinatus after the repair. The post-op rehabilitation, I think we need to be very gentle, very slow. Okay, not too aggressive, because the cuff tissue is very sensitive. If you go too fast, too much, your repair will be torn. Okay, and I will start my stretching exercise after 12 weeks. Okay, yeah, and the patient would have some stiffness at the beginning, but anyway, finally they will have good results. Okay, for taking home message, I think I'm in between. I'm in the middle between knotless and knotted, because I already changed 3 times. My first time I do knotted and I have a lot of type 2 tear, and I go to knotless. I found that there's still some gap underneath the rotator cuff. So now I go between. I do partial knotted tying. So this technique is less trauma to the cuff, less blood vessels, strangulation, and also less operative time. Yeah. So thank you. And we're going to have the APCAS meeting in this year in December. So I would like to invite of you to Thailand. It's on the 3 to 5 December. Go to our website apcas2020.org. Thank you.